Hi all. So our mm, next topic is scleritis. So before going to scleritis, I would like to say about a few words about the anatomy of sclera. You all already studied about the anatomy of eye, so I'm specifically telling about the sclera. Okay, so sclera, you all know that is fibrous cord of the eye, right? So in the fibrous cord also, it is divided into cornea and sclera. So the anterior 1/6 part is cornea, and the posterior 5/6 part of the fibrous cord is sclera. In that itself, the sclera is covered completely by Tennant's capsule. Okay, the complete 5/6 of the fibrous cord, that is, the sclera, is covered by Tennant's capsule. Also, in the anterior-most part, the sclera is covered by bulbar conjunctiva. Tennant's capsule is also there, and bulbar conjunctiva is also there. And then the histological division of sclera. Histologically, sclera is divided into three. Okay, first one is episclera, second one is sclera proper, and third one is lamina fusca. So, first one is episclera, second one is sclera proper, and third one is lamina fusca. So, this episclera is formed by connective tissue, and it is highly vascular area. This second one is the sclera proper, that is avascular part, and it is made up of collagen fibers. And third one is lamina fusca, which is the innermost layer, and it is in contact with the choroid. And choroid is, you all know, it's a pigmented layer. So this lamina fusca is also having little pigmented cells. So this is also dark in color, lamina fusca. So this is about the anatomy of sclera. So now we'll go into scleritis. So what is scleritis? Scleritis refers to the chronic inflammation of sclera proper. We told sclera is having three layers. Okay. Histologically, it can be divided into three layers. First one is episclera, second one is sclera proper, and third one is lamina fusca. So, the scleritis is a chronic inflammation of sclera proper. So, the middle layer. It is comparatively serious disease which may cause visual impairment and even loss of eye if treated inadequately. If we are not treating properly, it can cause loss of vision. Fortunately, its incidence is much less than that of episcleritis, so this is not a common disease. And it is usually occurring in elderly people 40 to 70 years, involving females more than males. So it is occurring in females and also in elderly people. So in this picture you can see this is the episclera part, and this is the sclera proper, and this part is the lamina fusca, the innermost layer. So this is sclera proper, and scleritis is happening here. Okay, here the chronic inflammation of sclera proper, that is scleritis. In this picture you can see this is how the eye looks. If a patient is coming with scleritis, this is how the eye looks. Next, we will go through the etiology, causes for scleritis. So, it is mostly associated with multiple conditions. In that, first one is autoimmune collagen disorders. So, scleritis is occurring along with autoimmune collagen disorders like rheumatoid arthritis. This is the most common, which will cause scleritis. Overall, 5% cases of scleritis are associated with some connective tissue diseases like rheumatoid arthritis, systemic lupus erythematosus, all those conditions. Okay. So 5% cases are associated with connective tissue disorders, and 0.5% of patients, that is 1 in 200, suffering from rheumatoid arthritis. So in 1 in 200 patients suffering from rheumatoid arthritis will develop scleritis. Other associated collagen disorders are venous granulomatosis, polyarthritis nodosa, systemic lupus erythematosus, and ankylosing spondylitis. So these will come under autoimmune collagen disorders. So scleritis associated with autoimmune collagen disorders. Next comes the metabolic disorders. Metabolic disorders like gout and thyrotoxicosis may also cause scleritis. Some infections, herpes zoster ophthalmicus, and chronic staphylococcal and streptococcal infection may also lead to scleritis. Granulomatous diseases like tuberculosis, syphilis, sarcoidosis, leprosy, all this after that secondary, there is a chance of getting scleritis. And miscellaneous conditions like radiations, chemical burns, and syndromes like Ward-Koyagnagi-Harada syndrome, Behçet's disease, and rosacea are also implicated in the etiology. Also, there is a chance after ocular surgeries, surgically induced scleritis follows ocular surgery. So it occurs within 6 months post-operatively. After the eye surgery, within 6 months there is a chance of getting scleritis. It's not like it has to come immediately after the surgery. It's not like that. After 6 months also there is a chance of getting, within the 6 months period, there is a chance of getting scleritis. That is surgically induced. Exact mechanism is not known, but maybe the precipitation of the underlying causes, systemic causes will be there. Because of this surgery, there is a chance of precipitating that one. And idiopathic, the cause is not known, unknown causes of scleritis. So these are the causes of scleritis. So first we told about autoimmune collagen diseases, then metabolic diseases, granulomatous diseases, miscellaneous causes like radiation, chemical burns and all, then surgically induced scleritis, and idiopathic, that is the cause is not known, unknown causes. So these are the etiology or causes of scleritis. Next comes the pathology. How the disease is forming. Histopathological changes are that of a chronic granulomatous disorders. It's like a granulomatous disorder. First, there will be fibrinoid necrosis. Fibrinoid necrosis means what? Cell death. So here, a uncontrollable and irreversible cell death can be seen with the deposition of antigen antibody complex in the walls of blood vessels along with fibrin. That is fibrinoid necrosis. So it's nothing. There is a cell death, that is necrosis. Cell death will be there, that is irreversible. We can't reverse that one. So irreversible cell death will be there, where it is seen in the walls of blood vessels, along with there is a deposition of antigen antibody complexes along with fibrin, that is fibrinoid necrosis. So first there will be damage in the blood vessels, walls of the blood vessels. Next, the destruction of collagen. There will be destruction of collagen together with infiltration by polymorphonuclear cells. That you know, if anywhere inflammation is there, there will be infiltration of polymorphonuclear cells, lymphocytes, plasma cells, and macrophages. So there is necrosis, cell death is there. Then there is destruction of the collagen there. After that, there will be infiltration of the polymorphonuclear cells. The granuloma is nothing but this infiltrated polymorphonuclear. The group of or the union of this polymorphonuclear cells is known as granuloma. So this granuloma is surrounded by multinucleated giant cells, epithelioid giant cells, and old and new vessels, some of which may show evidence of vasculitis. So this granuloma is surrounded by giant cells and along with old and new vessels. Old vessels will be also there and new vessels will also form, some of which may cause these blood vessels. In that, some may show evidence of vasculitis. Vasculitis is inflammation of blood vessels. So this is the pathology of scleritis. So first there is fibrinoid necrosis, cell death is there. After that there is destruction of collagen and infiltration of polymorphonuclear cells. These polymorphonuclear cells will join, or the union of these polymorphonuclear cells is known as granuloma, and this granuloma is surrounded by giant cells, multinucleated giant cells, and also old and new vessels. That vessels, there is a chance of vasculitis, inflammation of that vessels may cause. So these are the pathology of scleritis. So because we told causes of scleritis, now pathology of scleritis is over. Next comes the classification of scleritis. Scleritis can be classified into two: anterior scleritis and posterior scleritis. Most common variety is anterior scleritis. 98% we can see anterior scleritis and 2% only posterior scleritis. And this anterior scleritis is again divided into two: non-necrotizing scleritis and necrotizing scleritis. And this non-necrotizing scleritis is again divided into two: diffuse and nodular. And this necrotizing scleritis is divided into two: without inflammation and with inflammation. Without inflammation is also known as scleromalacia perforans. So these is the classification. These are the classification of scleritis. So scleritis can be classified into anterior scleritis and posterior scleritis. Anterior scleritis is again classified into two: non-necrotizing scleritis and necrotizing scleritis. This non-necrotizing scleritis is again divided into two: diffuse non-necrotizing scleritis and nodular non-necrotizing scleritis. And this necrotizing scleritis is again divided into two: without inflammation and with inflammation. So this is the classification of scleritis. So causes over, pathology over, classification over. Next comes the clinical features. That first one's symptoms. Patients complain of moderate to severe pain, which is deep and boring in character and often wakes the patient early in the morning. So patients complains about moderate to severe pain, which is deep and boring in character. So very deep and boring in character and often wakes the patient early in the morning. So it makes the patient wake up early in the morning. Ocular pain radiates to jaw and temple region. So it will radiate to temple and jaw part. It is associated with localized or diffuse redness, mild to severe photophobia, and lacrimation. So there will be localized and diffuse redness, mild to severe photophobia. Photophobia means aversion towards light, and there will be lacrimation, watering of eye. So these are the symptoms of scleritis. And occasionally there occurs diminution of vision. So occasionally there will be dimness of vision. So there will be severe to moderate to severe pain, especially early in the morning, and this pain will radiate to jaw or temple region, and there will be diffuse localized or diffuse redness and photophobia, mild to severe photophobia, and lacrimation will be there. Occasionally there occurs dimness of vision. These are the symptoms of scleritis. Next comes the signs. The salient features of different clinical types of scleritis are as follows. So here we are mentioning about the types. So in non-necrotizing anterior diffuse scleritis, there will be, it is the commonest variety and it is characterized by widespread inflammation involving a quadrant or more of the anterior sclera. This is the most common variety, and the inflammation is seen in a quadrant or more of the anterior sclera. You can see that in anterior sclera or in a quadrant, and it is the most common variety. Which one? Non-necrotizing anterior diffuse scleritis. So it is anterior scleritis. In that non-necrotizing, there is no necrosis and it is diffuse. It is spread everywhere. The involved area is raised and salmon pink to purple in color. So which area? The one quadrant or the anterior part of the sclera is involved. That part is raised and it is pink to purple in color. So this is a picture of necrotizing anterior diffuse scleritis. Okay. This is diffuse. It's not, you can see it is diffused. This is the most common variety, and the involved area is raised and it is pink to purple in color. Next type is non-necrotizing anterior nodular scleritis. So there is a node. So it is characterized by one or two hard, purplish, elevated scleral nodules, usually situated near the limbus. So nodule can be seen, scleral nodules are seen, usually situated near the limbus. Sometimes the nodules are arranged in a ring around the limbus, that is known as annular scleritis. Sometimes the nodules are seen not only in the side of the limbus, it can be seen around the limbus. Then that is known as annular scleritis. So this is non-necrotizing anterior nodular scleritis. It's near the limbal region and you can see a nodule in the anterior part of the sclera. So first type was non-necrotizing anterior diffuse scleritis. This one is non-necrotizing anterior nodular scleritis. Next comes anterior necrotizing scleritis with inflammation. Here necrosis is also there and inflammation is also there. So it is an acute severe form of scleritis and it is characterized by intense localized inflammation associated with areas of infarctions due to vasculitis. So this is the acute severe form of scleritis and it is characterized by intense localized inflammation. There will be localized intense inflammation and it is associated with areas of infarctions due to vasculitis. And the affected necrosed area is thinned out and sclera becomes transparent and ectatic with uveal tissue shining through it. It will become transparent and ectatic and with uveal tissue shining through it. So this affected necrosed area become thin. The thickness of the sclera reduced and it become thin and the sclera become transparent and underlying uveal tissue will shine through it. So we can see underneath uveal tissue through that part. It is usually associated with anterior uveitis. So the eye looks like this. Here you can see the sclera become very thin and this black portions are the underneath uveal tract. So this is anterior necrotizing scleritis with inflammation. And the fourth type is anterior necrotizing scleritis without inflammation. And it is also known as scleromalacia perforans. So there is perforation of sclera. So this is anteriorly and the scleritis is occurring in anterior part only. There is necrosis and there is no inflammation. This specific entity typically occurs in elderly females usually suffering from long-standing rheumatoid arthritis. The elderly females with long-standing rheumatoid arthritis will get this type of scleritis and it is characterized by development of yellowish patch of melting sclera due to obliteration of arterial supply which often together with the overlying episclera and conjunctiva completely separates from the surrounding normal sclera. So the overlying episclera and their conjunctiva will get separated from the surrounding normal sclera. So here what is happening, this is mostly seen in elderly females with rheumatoid arthritis, long-standing rheumatoid arthritis. Here first melting of sclera, yellowish patches can be seen in the sclera, that is called melting of sclera and it will get separated from the overlying episclera and the conjunctiva. The sequestrum of sclera becomes dead white in color, which eventually absorbs, leaving behind it a large punched out area of thinned sclera through which the uveal tissue shines. So what will happen there? There the sclera will become thin and the uveal tissue shines through that thinned out sclera. And spontaneous perforation is extremely rare. There is a chance of getting perforated, but spontaneous perforation is rare. You can see in this picture, this is the sclera, and here the thinning of sclera can be seen, and here you can see the sclera is separated and the uveal tract shines out through that perforated part. So this is the projection of uveal tract through the sclera. This is the sclera, and here it become thin and here it got perforated, and the underneath sclera you can see through that perforated sclera. So uveal tract can be seen through this perforated sclera. So this is scleromalacia perforans. Next comes the posterior scleritis. So this is seen in the, and from the name itself it's understood that it is seen in the, till now we were talking about anterior scleritis. Now this is posterior scleritis. This is seen in the posterior part of the sclera. It is an inflammation involving the sclera behind the equator. So when you learned about the anatomy of eye, you will go through this equator, right? So this posterior scleritis is involving behind the equator. The condition is frequently misdiagnosed. So there is a chance of misdiagnosis because it is characterized by features of associated inflammation of adjacent structures. So it will be along with associated inflammation of the adjacent structures, which include exudative retinal detachment. There will be detachment of retina from the underlying structure. Macular edema. There will be edema in the macular region. Proptosis. Proptosis means bulging out of eye, and limitation of ocular movements. There will be limitations of ocular movements. So these are the characteristics of posterior scleritis. There will be retinal detachment, macular edema, proptosis, and limitation of ocular movements. Then this is the fundal image, fundus photography of eye. So here you can see this is disc, optic disc, and this is the optic cup, and these are the arteries and veins inside the fundus. And this dark area is known as macula of eye, and here there is a chance of getting edema, macular edema, and this pale region is indicates retinal detachment. Normally it should be in this orangish color, full orange color only, but here you can see a pale area. This is retinal detachment due to posterior scleritis. So these are the signs of posterior scleritis. So there will be retinal detachment, macular edema, proptosis, that is bulging of eye, and ocular movements are limited. So this is about posterior scleritis. So these are the clinical features of scleritis. So first we mentioned about anterior scleritis. In anterior scleritis there are two types, necrotizing and non-necrotizing. In necrotizing, again diffuse and nodular, and that is in non-necrotizing, and necrotizing with inflammation and without inflammation. Next comes the complication of scleritis. These are quite common with necrotizing scleritis, and it include sclerosing keratitis. Keratitis is inflammation of cornea. Keratolysis. This is a bacterial infection of the skin. And complicated cataract. Chance of getting complicated cataract and secondary glaucoma. These are the complications of scleritis. Investigation should be done to understand the underlying pathology. So following laboratory studies may be helpful in identifying associated systemic diseases or in establishing the nature of immunologic reaction. So these investigations are done to understand the systemic diseases associated with the scleritis. So TC, DC, ESR can be done. Serum levels of complement immunological survey can be done. Immunocomplex, rheumatoid factor, anti-nuclear antibodies, all these things can be done. To find out whether it's associated with syphilis, they have to do FTA, ABS, VGRL. And for gout, we have to see serum uric acid level, and urine analysis can be done. Mantox test for TB, X-rays of chest, paranasal sinus, sacroiliac joint and orbit to rule out foreign body, especially in patients with the nodular scleritis. All these things are investigations. Next comes the treatment. Treatment can be divided into non-necrotizing type and necrotizing type. In non-necrotizing type, it should be treated with topical steroid eye drops, and systemic anti-inflammatory drugs can be given. In necrotizing scleritis, it is also treated with the topical steroids and a heavy dose of oral steroids also in necrotizing, and it is tapered slowly. So in non-responsive cases, immunosuppressive agents are given. So these are the treatment for scleritis. So scleritis treatment is divided into non-necrotizing and necrotizing scleritis. So both the cases, steroids, topical steroid eye drops are given, and in non-necrotizing the anti-inflammatory drugs are given, and in necrotizing internally also steroids are given after the dose is tapered. So if it is not responding for that, then immunosuppressive drugs are given. Then subconjunctival steroids are contraindicated. This is not given. So that's about scleritis. So these are the factors about scleritis. So we dealt with the etiology, pathology, and clinical features, then complications and investigations, then last about the treatment of scleritis. Hope you all understood scleritis. Thank you.